Hi, everyone. We are going to do a quick overview of the basic anatomy and physiology of the liver so that we can go over the pathologies associated with the liver and its buddy, the pancreas. So, for this chapter, the first part involves knowing the typical function and structure of the liver and pancreas. If you know the normal function, the pathologies should be an absolute breeze. Then there are a couple of different types of disorders that can affect the liver. You probably all heard of hepatitis, inflammation of the liver. And then there is liver failure, cirrhosis, pancreatitis, which can be caused by liver cirrhosis and swelling and failure. So those will all come together in a family. And then we'll talk about the diagnostic screening methods used to find these different disorders. So first off, just anatomically, the liver is the largest internal organ and it compromises the largest amount of body weight for an organ and also takes up the largest amount of cardiac output. It's very busy. So it's in the upper right abdominal quadrant, the largest internal organ, 2% of the body weight. And from the front, it looks like the liver is just two lobes. There are some lobes on the back that we'll see. But from the front, there is a smaller left lobe, a larger right lobe. Those are held kind of together and in place against the wall by the coronary ligament, which is associated with the falciform ligament ending in the ligamentum teres, which you see here at the bottom. That's actually a remnant of the fetal umbilical cord. So fun association with development. And hiding behind the liver is a gallbladder. And the gallbladder is right next to or kind of behind a healthy liver. And it is able to store bile that the liver is creating so that the gallbladder can store a little bit extra. When we look at the liver's blood supply, it has a huge amount of blood coming to it and going away from it. It also has a specialized system called the portal system. But typically, we are looking at a huge amount of blood going into the liver, and it also acts as a body reservoir for blood. It has a huge ability to just store large amounts of it. About 1.5 liters a minute of blood go through the vessels of the liver, which makes about 2,000 liters per day. So that the liver can physically metabolize, which means change the things in the bloodstream, whether they be products of digestion or cellular metabolism, drugs, toxins, really anything that enters the body cannot leave until the liver has changed it in some way. There are, of course, some exceptions to that rule. Obviously, oxygen doesn't need to be changed by the liver, but a large number of products do have to be. So looking at this blood supply, how does all that blood get there? Well, right off of the aorta, there are the hepatic arteries. So this is a typical organ structure with an arterial and venous supply. So the aorta conveys the hepatic, which means liver arteries that come out to go bring fresh oxygenated blood to the lobes of the liver. And then we have the hepatic vein draining these hepatocytes, the cells of the liver, through the central venous system. Then there is a specialized system called the portal vein. And the portal vein is here in purple. And the reason it's not bright blue like other illustrations of veins is because it doesn't contain all deoxygenated blood. The portal vein is directly attached to the intestines. And it drains the intestines and conveys that blood straight up through the portal vein to the liver. And this is where the liver gets 2/3 of its blood supply. And it's draining the intestines so that as nutrients and oxygen and things are broken down by the intestines, they can be shunted directly up the portal vein to deliver these fresh nutrients, fresh oxygen right to the liver. So this is a specialized system. Whenever you see portal in the body, it usually means going in the opposite direction. But this is something that's acting almost like an artery. It's going out to the organ to bring it nutrients and oxygen. When we look at the microscopic organization of the liver, we see a couple of things that you should notice. First off, there are Kupffer cells, which are scavenging phagocytic cells. They are the tissue-specific monocytes of the liver. So if any pathogenic material gets there, the Kupffer cells, just like security guards in one area, would be able to remove a specific pathogen just at the level of the liver. There are specialized types of capillaries in the liver called sinusoidal capillaries. They're the leakiest and most permeable capillaries in the body. You'll find sinusoidal capillaries in places like the bone marrow as well. And these are important for allowing the transit of large products like fats, so our LDLs, HDLs, and also big proteins to travel and be modified in the liver, things that are too big to go through a typical capillary. Then everything here in green, so are things associated with the bile. So hepatocytes, which means liver cell, hepatocytes are the active liver cells and they're creating bile constantly. And those hepatocytes convey that bile through canaliculi, a fun word to say, canaliculi, which means little canals. And the canaliculi, they join together to form larger ducts and vessels until they finally turn into the bile duct. And the bile duct is a really large draining duct that will bring the bile, an exocrine product. Remember, that means created and then conveyed to the outside of the body, not the bloodstream, to the outside of the body. Technically, the GI tract is outside of the body, even though it's a lumen that runs through the inside. And you can remember that by thinking, if the GI tract, like if the intestines broke open, would we want all of their contents mixing with the inside of our body? No, absolutely not. So when bile is excreted into the duodenum, it's technically being excreted into the external environment. So this is an exocrine type of product. And these hepatocytes, they are organized into the functional unit of the microscopic liver called lobules. And a lobule is this like 6-sided structure. So this is a close-up of what's inside of a lobule. Again, you see your Kupffer cells. Those are your specialized tissue monocytes. Hepatocytes are the active liver cells. Here's your sinusoidal capillary, nice and leaky, allowing transit of large products. And then you see our bile canaliculi, these green things conveying bile down to the bile duct. We also see this large hepatic portal vein here. I love this term, hepatic artery or artery proper, the proper one. That's the nice one. So these are the functional units, and this is the way things are organized. And each of these lobes is separated from one another by a septum. So it's called the interlobular septum. Interlobular, between each lobule septum. And that is the functional unit. So we saw that hepatocytes, they are responsible for the creation of bile, and they're always working, and they're spreading the bile down first through those tiny little channels, the canaliculi, which eventually converge together into larger bile ducts. There's a right and left hepatic bile duct. So those are the ones in the liver. That's why we call them hepatic bile ducts. And that bile, as it's created, will flow down eventually into the common hepatic duct. So everything coming from the liver, left and right, common hepatic. And it will flow down the common bile duct. When that fills, the remaining bile can come and fill up the gallbladder. And the duct that leads to the gallbladder is called the cystic duct. So the cystic duct leads to the gallbladder, which can store even more extra bile. I want you to also notice that the common bile duct converges with the pancreatic duct. So this would be the pancreas here, right below the stomach. The pancreatic duct, they get together with the common bile duct, and those are controlled by the sphincter of Oddi, or the hepatopancreatic sphincter. And that little hole inside of it that can open up is the ampulla of Vater, German for water, ampulla of Vater. So pancreatic juices and bile from the liver, they're released at the same time. So again, the canaliculi, they go to the hepatic ducts, first right and left, and then the common hepatic duct. So there you see that. And then the hepatic duct and the cystic duct converge to make the common bile duct. The common bile duct and the pancreatic duct, they will eventually come to form the ampulla of Vater, which is controlled by the sphincter of Oddi. So there you go, sphincter of Oddi. So when the sphincter of Oddi is contracted, bile and pancreatic juices remains in here. When there is the release of products, so when food is going from the stomach into the duodenum, one of the breakdown products of proteins causes the release of something called CCK, cholecystokinin. Like cysto, see how it says cystic duct? That's referring to the gallbladder. So CCK, cholecystokinin, it goes through the bloodstream, goes up here through these vessels, and it triggers the gallbladder to contract. It's covered in smooth muscle on the inside. So the gallbladder contracts, and when it contracts, it's going to force the bile that it's storing out into the common bile duct, and the pressure will become so high in these ducts that it will force that sphincter of Oddi open, allowing the pancreatic juices and the bile to enter the duodenum. That will help to neutralize the pH of the contents, because the pancreas makes bicarbonate, and the bile here will help break down fats. So this is, again, the pathway of bile. We are looking here at the liver, the hepatocytes, they collect it, canaliculi, right and left hepatic ducts, common hepatic duct, common bile duct, here's a pancreatic duct, getting together to make the ampulla of Vater and then the sphincter of Oddi. And when CCK is released, gallbladder contracts, and then as you see here, all that stuff can enter the duodenum. All right, so when the sphincter of Oddi is closed, bile can back up into the gallbladder, and the gallbladder can store 50 mils of bile. So that's quite a bit of bile. If somebody has their gallbladder removed, they have to be on a low-fat diet because bile is necessary to break down fat. If somebody has had their gallbladder removed, they're still creating bile, but they're not having any of the extra stored bile being held by the gallbladder. So they're just relying on the continual creation of bile that will just be hanging out in the common bile duct. So again, fat in the duodenum and breakdown products from fat and protein cause the release of CCK, the gallbladder contracts, and then the sphincter of Oddi relaxes, and bile and pancreatic juices enter the duodenum. And so when bile is, this says secreted, it should say excreted, but that's okay. But when bile is secreted, yeah, we'll go with that right now, into the duodenum, a couple of things. The first thing is that there are two types. There's cholic acid and chenodeoxycholic acid. That is important if you're interested in hospital care, because when somebody has deficient bile salts, you give them something like chenodeoxycholic acid to help them degrade their fat products. The function of these, A, is to emulsify fat. And to emulsify means to take a globule and make it into smaller pieces. So here's a here's a big glob of fat. That would not be broken down in the absence of bile. But instead, when there is sufficient bile salts, the bile salts, they bind to the surface of that fat, and then they allow it to break up into tiny little globules. And that allows for a proper feces. In the case where somebody has bile salt insufficiency, where they are either not making enough bile, there's a blockage of bile flow, or they've overwhelmed their bile stores by having a very high-fat diet, the fat, instead of being broken down, will remain as fat. So the stool is very Smelly, we call that malodorous. So it smells really bad. It's difficult to flush. It's oily. And you can physically see these globs of fat on the top of the water because you guys know oil and water don't mix. So it looks like oily water. If you've ever seen like oil in a puddle, that's what it looks like. So you need to have bile to emulsify fat so that the feces don't look like that and the products of fat can be absorbed. And you cannot then absorb the products of fat without bile. So that's the second function. When you have fat in the diet, like in oils, it makes your skin soft, your hair soft. You use it to make your steroid hormones, your cell membranes. So there does need to be some amount of fat in the diet for function. Bile makes fat water soluble so that it can be mixed into the parts of our body that need it. Otherwise, as I just mentioned, the fat just continues going on. Oil and water don't mix, and then it eventually ends up at the top of the toilet water. And then another very important thing that you can see, because if this doesn't happen, there is a clinical finding, is the excretion of bilirubin. So bilirubin is a breakdown product from red blood cells. So remember, when red blood cells are broken down, they're broken down into their iron ring, which is trafficked around on this transferritin trafficking protein and stored as ferritin. The globular portion is broken down into amino acids, and then the heme portion is broken down into bilirubin. And so bilirubin is going to be around anytime there is, here, let me get rid of my drawings. It's a smelly, oily. So bilirubin will be down anytime there are broken down red blood cells. And you've probably seen this yourself if you've had a bruise before. The bruise is first like dark purple or blackish, and then as it heals, it starts to take on a yellowish complexion. That's because those red blood cells are being broken down by the immune cells in the body, and now there's leftover bilirubin as the hemoglobin's broken down. So the way that bilirubin can be removed from the body is first to have it conjugated. And conjugation is a reaction that happens in the liver. It's a metabolic reaction. And to conjugate means to add something to it so that it can be excretable. In this case, it's conjugated to something called glucuronic acid. And glucuronic acid is something that your body can excrete readily. Your body cannot get rid of unconjugated bilirubin. That just hangs out in the bloodstream, and it is neurotoxic. So it's important that bilirubin leave. So the liver has to be active first to conjugate bilirubin so that it can be excreted. And the second thing the liver needs to be active for is to make bile. Bilirubin is excreted through the feces. When things are incorporated into the feces, it is done so with bile. So bile needs to be created by the liver for it to be excreted in the feces. 90% of bilirubin is excreted in the feces. And first, it needs to be conjugated so that it's able to be excreted in the feces. Your body can't just pee out bilirubin. So if somebody starts turning yellow with jaundice, their kidneys can't just pick up the slack because we still can't urinate out non-conjugated bilirubin. It still has to be conjugated. Once it's conjugated, then it can be excreted. So the liver is required to conjugate it and to make the bile. So bile is necessary to break down fats, to absorb the products of fats in the diet, and to physically remove bilirubin from the circulation. So this is an active metabolic map. If you're really into biochemistry, you can check out this map. These are all the different reactions you learn about in biochemistry, so you can click on any one of these and then learn more about it. I'm sure you want to do that all day, but let's keep our eyes on the prize right now. So this is a reaction map. These are all the different products that the liver is involved in. So it breaks down lipids, carbohydrates, glycogen, glucose, amino acids, all these things that we want to be able to use as stores or fuels in our body, the liver has to first change them into a usable form, and that's called metabolism. So the liver is the main organ of metabolism. When proteins are metabolized, those amino acids have to be deaminated. If they're not deaminated, then they cause brain damage. They cause an encephalopathy. Usually they leave in a form of a nitrogenous waste, which is called urea. That's a large component of the urine. So that's normal metabolism. You might also know that the liver metabolizes drugs. So to make that more simple, I just call that metabolism usually, but we can call that detoxification. So when somebody's going on a detox, diet or a detox, like a juice cleanse, that's what your liver does. That's your liver's job, is to detoxify things. That means it's going to take it and make it excretable. So this is the simplest way to explain it. Drug in, so everything that goes into your body that creates an effect is called a drug. Caffeine is a drug. So here's caffeine going in. In order for caffeine to leave, some magical liver enzyme has to change it into an excretable form. So see how it's yellow here? That means you can pee it out. So drug in, enzyme magic, excretable form. Those leftover products from the drug that's broken down are called metabolites. They're just byproducts. Whoa, what happened? Okay, so when there is changing of drugs, we call that, again, detoxification. And those different phases, there's two different ways that we do that, and they happen in order, which is why we call them phase 1 and phase 2. So when a drug comes in, like caffeine, the first thing that happens is a phase 1 reaction, which are very simple reactions, just splitting the drug into pieces. So those could involve oxidation, reduction, hydrolysis, and they involve large families of enzymes called the cytochrome P450s. Who cares? Well, that's something that you need to know, because drugs don't just come out of you as what they went in as. If you take an aspirin, it doesn't just come out as aspirin. Your body has to change it into a form that's excretable. The reason why certain drugs can't be taken together are because they use the same cytochrome P450. There's about 10,000 of them. So you might have heard that if people take Lipitor, they can't eat grapefruits or drink grapefruit juice. That's because both Lipitor and grapefruits use the same cytochrome P450. They use the cytochrome P450 2A3. You cannot take two drugs that use the same enzyme. There's not enough of them to go around. One of them is going to go to toxic levels in the blood, and it can kill you. So that's how we have drug interactions. Phase 2 are the more complicated reactions that add something to the drug to make it water soluble so that it can be removed through the urine. So those involve sticking it onto things like methyl groups, sulfates, acetylation, glucuronides. We just saw bilirubin. It's attached to glucuronide. That's how it leaves. Glutathione. So those are the addition of products to make it water soluble so it can be incorporated into the liver. Well, who cares about that? So this was drug interactions, our phase 1. Phase 2 is species differences. That's my little dog Dylan. He's 13 now. He looks a little bit different, a little bit more scraggly. But there's one thing, well, there's a bunch of things that dogs are not supposed to eat because it's going to kill them. One of them is chocolate. And the reason dogs should not eat chocolate is because it contains a large amount of methylated theobromine. So see here, methylation is a phase 2 reaction. We have tons of methylation enzymes. So when humans eat chocolate, our methylation enzymes in the liver add these methylation groups, these methyl groups to the chocolate backbone so that it can be peed out of the body. Dogs, canines, do not have methylation enzymes. So therefore, they eat some chocolate. There's no methylation enzymes to make it water soluble. They can't pee it out, so it builds up in the bloodstream and it becomes toxic. So that's how we get species differences. For humans, that's also how we get age restrictions on medications. So drugs that are removed via glucuronidation are the safest for kids and the safest for the elderly, because those enzymes are the first to pop up during development, and they're the last ones to die across the lifespan. So certain medications you can't give kids until they're 12 or 7. That's because those enzymes have not physically been created yet. Some drugs are not recommended for people over 60 or 65 or 80. That's because some of these enzymes die. So phase 1 reactions, which are just to split things into component pieces, those determine drug interactions. Phase 2 are the addition of products to make them water soluble, and those are what determine species restrictions and age restrictions on medications. Okay, alcohol works a little bit differently. I'm going to talk about it really briefly because alcohol has a lot to do with the liver. One of the things that's weird about alcohol is that it doesn't really use the phase 1 system that strongly. Instead, it uses its own enzyme that's down here. But there's a little bit of phase 1, which is the cytochrome P2E1. And when this is induced by alcohol going into the liver, alcohol is broken down into ROS's reactive oxygen species. So those are your that's what antioxidants work against. The buildup of reactive oxygen species in the brain is really dangerous for you, changes cell signaling. It's involved in like Alzheimer's disease, dementia, cancers. So we don't want a ton of induction of this, but that's what happens. There's a little bit of induction. Normally, though, alcohol is acted upon in a special way by its own enzyme called alcohol dehydrogenase. So alcohol is a different drug. It doesn't have a half-life. Instead, a standard amount, it's 1 to 1.5 drinks an hour, are removed from the body in every person, regardless of who they are, how much they weigh, what their nationality is, what their gender is. It all is about this enzyme. Everybody has the same amount of alcohol dehydrogenase, and it can only break down 1 to 1.5 drinks an hour. So alcohol is broken down by alcohol dehydrogenase into the first product called acetaldehyde. And acetaldehyde then is broken down into acetate, which is used in the Krebs cycle for like energy and stuff like that. So let's make this interesting. So ADH, this big old enzyme, alcohol dehydrogenase, converts, same thing, 1 to 1.5 drinks an hour into acetaldehyde, which then is broken down into acetate by acetaldehyde dehydrogenase, which has the same time restriction, 1 to 1.5 drinks an hour. So that means if somebody drinks more than 1 to 1.5 drinks an hour, they're going to have only so much alcohol being broken down. They're going to start to increase their levels of acetaldehyde. And when levels of acetaldehyde are high, people feel really tired and cranky and nauseous. They get light sensitive, sound sensitive. They don't want to do anything. They throw up sometimes. They feel awful. What does that sound like? That's called a hangover. That is the definition of a hangover. A hangover is the buildup of acetaldehyde in the body, period. There is a drug then that like breaks this down, like ALDH. It stops this from working and causes acetaldehyde to build up. And that's called Antabuse. Sold as the generic is disulfiram. And this is a drug that people take every day so that when they drink, they start to build up acetaldehyde. It's not broken down at all. So they right away get really sick from it. So it's supposed to keep people from drinking because they associate being sick with drinking. So that's fun, right? ALDH and leading to the buildup of acetaldehyde, that's the basis for hangovers. There's one other thing that has a implication, for heavy drinkers. When acetaldehyde is broken down by ALDH into acetate, acetate, you might know, is not a good product. That's what we remove nail polish with. It's a chemical. It's a really strong chemical. Remember in the GI chapter, we talked about the area postrema in vomiting, and that's there to sense levels of poison in the blood so that it can instigate vomiting. When that is activated, you are required to be vigilant. So there might be a time when somebody drinks like 10 Long Island iced teas and they're like, I'm going to go to sleep forever. I'm going to pass out. I'm never going to sleep so good. And then at 3 a.m., they're awake and they can't go back to sleep. They're just up. Well, that's because that part of their brain that senses poison is signaling to the part of your brain that keeps you awake because it senses high levels of acetate, which is a poison. So it's like, why are you sleeping right now? We've been poisoned. You need to wake up before we die. So this is the physiologic basis for hangover, and this is the physiologic basis for early morning wake-ups after heavy drinking. See, science can be fun. All right, so a couple of things just before we get into the pathology. We will see that the liver is pretty good at not failing. That is because it has a huge reserve capacity. Only 10% of those cells are active at any given time, which means only 10% will be damaged. It's also a highly labile tissue. It's not quite labile, but it's almost there, which means it's really good at regenerating. It can regenerate in the case of injury in a very strong sense. So it's really good at growing back and healing itself. However, because of the portal system, which is meant to deliver nutrients and oxygen to the liver, it drains the intestines and shunts right up to the liver. That also means anything toxic that's ingested will go directly to the liver and it will be subject to direct blood flow from the GI tract. So it has this ability to regenerate, to try to keep itself safe, but because of the anatomy of the portal system, when people are doing a lot bad things for extended time frames, the liver is at risk for really diffuse damage. And the damage tends to be quite diffuse by the time signs and symptoms appear because the liver is so good at compensating for itself. All right. Thank you for listening to my intro lecture.